So obviously precision medicine is a very large topic, and I'm going to try and focus it as an example of how we're using it to develop better treatments for dementia, both therapies and ways of preventing. So in a nutshell, precision medicine is about the right treatment for the right patient at the right time. In psychiatry, we deal with heterogeneous populations. If you appreciate here, the different colors denote individuals with different backgrounds that speak to therapeutics. So in a psychiatric patient population, we often have a very heterogeneous groups. And this slide on the left is depicting individuals who make up a patient population, let's say for our sake of argument, people who have dementia. But in fact, within that group, there are many different ways through which people get dementia. So right now, our standard approach has been to take all treatments that we think are going to be good for dementia, and we give them to everybody, ignoring the possibility that they might have different backgrounds. And so, pardon?
Could you put your slides into slideshow, maybe? We are seeing all your slides at once at the moment.
Goodness, they were in slideshow on my end. So back to the point I was trying to make, I hope you can see the arrow that I'm using on the screen. So here we have a group where we're giving a therapy that only works for some, but we're giving it to all. And as a result, we have a number of challenges. First of all, we give it to all. If it only works for some, we might fail to detect that it works for some just because the presence of people for whom it doesn't work in the population dilutes the benefit.
I am so sorry, doctor. I think we are stuck at very different slides.
Oh.
I'm afraid it's not starting from the beginning, so we don't know where we can see the cursor now. But we're on slide number 26 and 27 and 28. Heterogeneous
patient population depicted by people in different colors here. We have a treatment that only works for some that we're developing. We try it out, but we give it to everybody, not mindful of the fact or not having figured out that it might only work for some. And so one risk is we might not detect benefit because we have too many people for whom it doesn't work in the population. And so that dilutes out the treatment signal in a treatment study. The second is if it only works for some and we're giving it to everybody, we're exposing people for whom it does not work to risk. And then, of course, we're also wasting our time and energy. So in psychiatry, taking the standard approach, I think, has served us well to some extent, but we really need to start shifting to a more tailored approach, being able to understand the different backgrounds of individuals and then applying the treatment that's going to be specific to the individuals in the different colors here. Take an example, we all know that when we treat people with depression, with an antidepressant, only about a third will get much better with the first antidepressant, and many will get better with the second or third. Well, wouldn't it be nice if we can figure out from the beginning who the person is who's going to respond to a particular treatment? And that's really what precision medicine is about. I do want to point out that it's a culture, it's a way of thinking. Many people I've heard present precision medicine as, oh, we go out to X population, we're going to get all the information we can on them, whether it be clinical, genetic, biologic, and we're going to follow them and we're going to see where it shakes out. I think the collection of all these data is very important to precision medicine, but it is not the essence of precision medicine. The essence of precision medicine is the prior hypothesis that there are subgroups and that really this exercise is about finding them, and not just any subgroup, but subgroups that are going to be relevant to therapeutics. Switching to the dementia area, I want to be sure that we're all on the same page with some very brief definitions. So usual aging or usual cognitive aging refers to the fact that as we all get older, there are some changes in our memory and other cognitive abilities. So usual aging means that when we're 70 or 80, our cognitive functioning is less good than we were 30, 40, or 50, and that some of that change is simply the result of us getting older. But we have this additional construct over the last few decades, cognitive impairment, not dementia, CIND. And this refers to the fact that we are not aging with our cohort. If we were, say, in the 50th percentile for our age cohort in cognitive functioning, and we are now on the 25th or worse on the 10th percentile, it means that we've fallen off where we should be. And if we're still functioning quite well, we refer to that as cognitive impairment, not dementia. It's cognitive impairment because we are now more cognitively impaired than we should be based on where we have been with our cohort. We're not 50th percentile, we're 10th percentile. But we also are functioning enough so that we cannot qualify for a diagnosis of dementia. Embedded in the broader category of CIND is the subgroup of people who we say have mild cognitive impairment, and that these days is generally referring to the prodrome of a particular kind of dementia called Alzheimer's disease. The other definition is neuropsychiatric symptoms. You'll hear a bit more about those later on, but these are symptoms that are not part of a traditional, if you will, major psychiatric disorder, such as major mood disorder, bipolar, schizophrenia, PTSD, OCD. But these are symptoms that we have been showing in many groups across the world start to develop in individuals, aging individuals, especially after age 60 or 70. And that sometimes these come together to form a syndrome of late onset behavioral symptoms that are impactful or in interpersonal and social functioning. And that syndrome we now refer to as mild behavioral impairment. And the evidence is pretty solid right now that both MCI and MBI are prodromal states to impending dementia. I'll show you some of the data for MBI later on. Dementia then is where we have cognitive impairment with a functional effect. And that's really the border between CIND or MCI and dementia. Someone who's fallen, say now, to their 10th percentile of their cognitive function for their cohort, but they no longer are able to drive or function in ways that they could before. And how we define that a little bit depends on their age. So someone who's 56 has cognitive decline, can no longer work, that would be dementia. Someone who's 82, who's got cognitive decline, can no longer live independently, live alone, that would be dementia. We would use that sort of a criterion. It's critical that we differentiate these clinical states, usual aging, CIND, MBI, dementia, from what's in the brain. And just to emphasize that Alzheimer's disease is the cause of dementia or MBI or MCI, but it's not actually a clinical syndrome. So whereas we can diagnose dementia clinically, we cannot diagnose Alzheimer's with 100% confidence clinically unless we apply biologic tests, and we have more and more biologic tests that are available to us now. And the same is true for Lewy body disease or frontotemporal degeneration. I should also mention brain vascular disease. Those are the four major causes, at least in the US, of what we see of dementia. So hopefully those definitions will be a good foundation for you now. To move on to the reminder, across the world, we have a growing number of people living with dementia. These are the numbers starting for 2015. These are, if you will, projected counts. They're not prevalence estimates. But for 2015, across the world, it was estimated that 46 to 47 million people were living with dementia. You see the distribution, the number in Africa, relatively speaking, is smaller at 4 million. But these increases that you see over time, which represent, in some instances, a doubling or tripling over every 20 years or so, reflect simply that the populations are aging, that we've been very successful as societies to help people grow older, but when they grow older, they're more likely to get dementia. Now you would say, well, okay, if you just take a worldwide estimate, 131 million in 2050, is that really a big number given the numbers of other conditions that we're dealing with across the world? And that's a fair question. But I think one has to remember that these are 131 million people who will live 10 to 15 years with a disabling condition. and that each of them will require 2 to 3 caregivers to help take care of them because of the kind of disability that they have. So these are chronic, severe, disabling conditions that require a lot of support. So once you put that in perspective, you can appreciate that at least in the United States, we are projecting dementia will be the most costly public health condition over the next 25 to 30 years. And obviously there's a huge effort to try and delay it or prevent its onset. I will quickly now switch gears to talk about how we have been approaching Alzheimer's disease, which is the major cause of dementia, and we've been approaching it using the amyloid hypothesis. So there's a genetic basis for which the belief is that this amyloid precursor protein, which exists in the walls of all neurons, is misprocessed across a lifetime. The misprocessing happens much more frequently later in life, and it leads to the accumulation of oligomers referred to as A beta 1 to 42, that these can assemble into groups of plaques, and that probably the oligomers, not so much the plaques, begin injuring synapses and neurons, lead to the intracellular tangles, neuritic tangles, neuronal loss, eventually circuit loss and symptoms. This is very simplified, obviously, but it's that way because the hypotheses have been simplified, because it's saying all we need to do is deal with the problem with amyloid, and all the other stuff down this cascade is going to go away. So with that approach, there have been many amyloid, as I call them, amyloid busting therapies developed and tested for many years. And so where are we now? Well, with this hypothesis, after 40 years of research, we have 4 approved symptomatic therapies. The 4 approved symptomatic therapies are just that. They don't change the course of illness, although they are very modestly helpful. Nothing in the last 17 years until June of last year, where in the United States, we had the approval of aducanumab. I'll come back to that in a moment. And in my view, we still don't have any clear disease-modifying therapies. And in fact, the many amyloid therapies have been tested. And for the most part, if you look at clinical outcomes, they have not been shown to be superior to placebo. In fact, therapies that seem to inhibit the production of this toxic amyloid seem to lead to cognitive outcomes that are worse than placebo. So raises significant questions. But in the last year, we had the approval of aducanumab. Aducanumab is a very effective antibody that's able to penetrate the brain and reduce the amount of amyloid that exists in the brain. And so that is pretty much an agreed upon outcome, that aducanumab and drugs like it seem to really make a difference in clearing amyloid from the brain. And one clinical study for aducanumab, known as eMERGE, suggested that it might also have clinical benefit. So let me just orient you to this slide. The x-axis is time over 78 weeks. It's about 1.5 years. The y-axis is CDR sum of boxes. CDR-SB, as it's referred to. Actually, the scale is widened. Really, the CDR-SB, over time, someone with dementia, as they worsen the CDR-SB, goes up. And the typical increase is 2 to 3 CDR-SB points worse every year. So what we're seeing here is a blown up example that goes from 0 to 2. So if you think about it, 0 to 2 is about a year's worth of decline that you expect to see in a year in someone with Alzheimer type dementia. So in this study, individuals received placebo, low dose aducanumab infusions, which are monthly infusions, or high dose aducanumab infusions. Remember, higher is worse. So everybody started, if you will, here at the 0 point. The placebo folks follow this trajectory in the gray line. And you see that they approach over 18 months, maybe an increase in about 1.6 in the CDR-SB, a little bit less than what one would have predicted. But in the high dose aducanumab, we actually see a statistically significant difference at 78 weeks, not earlier. And this difference is on the order of 0.3 of a CDR-SB point. So it's a very small advantage, but it can be shown to be statistically significant. So you might say, okay, we know this drug clears amyloid. Here's a study that says that it helps, but then notice a couple things. First of all, everybody, including on high and low dose aducanumab, are steadily worsening. And the benefit here at 18 months is really very modest, very small, and probably not clinically significant. In fact, based on the prior assumptions of the company that developed this, it is not clinically significant. Next to emerge, there was another study called ENGAGE, pretty much identical, except in ENGAGE, there probably was less dosing of a higher dose. What are the outcomes here? Again, the same parameters, time, CDR, SB. Here are the trajectories. And notice here, you've got a very different outcome. Placebo is between high and low dose. Low dose seems to be the best. High dose seems to be the worst. But the differences are really small and not, in my view, clinically meaningful. So the FDA in the United States, and what I personally think was a very misguided approval, said, okay, we put this drug on the market because it clears amyloid. And we expect the company to approve that it also clears clinically, that it improves people clinically down the line, excuse me. We shall see what happens. Happy to engage with you on that in the Q&A if that's helpful. Let me see, there seem to be things in the chat. Okay, I want to make sure I'm not missing any questions. Okay. But aducanumab is not in vacuo, so actually there have been enough therapies with amyloid in clinical trials that gave the opportunity for this very impressive meta-analysis, which looked at not the CDR-SB, which is a somewhat impractical research tool. Rather, it looked at outcomes on the mini mental state exam, which is, I think, the gold standard, if you will, for a clinically meaningful change on the clinical side. And what did they essentially show is, well, they took all these clinical trials, they looked at the amount of change in amyloid reduction, and they looked at the amount of benefit that occurred on the MMSE. So here in the small print, I'll read for you, the pooled estimate for the effect of reducing amyloid levels by 0.1 standardized uptake value ratio units, so that's for a certain amount of amyloid level reduction, was an improvement in the MMSE score of 0.03. Now, someone with a mini mental typically declines 3 to 4 points a year. So this is 1/100th of that in improvement, and it's really not statistically significant. So aducanumab and other drugs that clear amyloid produce a certain amount of amyloid reduction, but the amount of clinical benefit that's directly correlated with that amyloid reduction is either non-existent or negligible. So it's based on this evidence that I think the amyloid hypothesis has really not been terribly advantageous. So it leads us then to the next question, what's the problem? Well, it could be wrong. It could be too restrictive. It may be that some people will benefit from amyloid reduction clinically, but others won't. We need to figure that out. It also assumes Alzheimer's is a single disease entity, meaning that there might be other therapies and other ways to think about amyloid. Amyloid does accumulate as the brain disease progresses, but is it the cause or is it the tombstone? And if it's the tombstone, meaning it's an indication of a different process as opposed to the process, how do we separate that, and does that apply to everybody the same? The other point to make is that all of these immune therapies for Alzheimer's disease have come into man after being tested in mice. Now, these are mice that have had human genes inserted that lead them to have the brain phenotype that we see in people with amyloid accumulation, tau fibrils, and neuronal loss. And all these drugs, including aducanumab, are very highly curative of Alzheimer's in mice, but not so fast in people. So maybe we knew different models, not animal models, but human models. And this is where a whole new generation of testing platforms are going to come into play. These are stem cell driven or induced pluripotent stem cells driven. We'll come back to that. And also, maybe we are studying the wrong people. Pretty much all the research for these drugs are in people who come to research centers, typically in the US and Europe, and some in Asia now, some in South America. I honestly not familiar with the situation in Africa as to whether individuals in Africa are also involved in these trials. And so we may be studying the wrong people. These people probably represent fewer than 10% of all the people with dementia or who will get dementia. And remember that I told you that we expect people in the population setting to worsen about 2 to 3 points a year on the CDR-SB. Well, in these studies, we're seeing people who are worsening maybe 1.5 or 1 point per year. So really a milder population. And so even if we could show that these drugs work on this milder population who don't have many comorbidities, how helpful are they going to be in what we would call the real world out there? So we think that the paradigm needs to be shifted, that we need to go to a paradigm where we understand that this is a much more nuanced disease, that there isn't a single pathway down, that there are upstream genetic and other aspects. So how much stress has the person been exposed to? And by stress, I think you know what I mean. Trauma, reserve, genetics, all of these we think are upstream to the accumulation of the oligomers, that there are other processes that you see here as possibilities. And that ultimately, this is going to be much more nuanced, where people go to each stage in an individual way, so that if we're going to intervene, we need to be thinking of the stage at which they are at and developing a therapy for them. So for example, maybe there is future for A-beta well before the onset of symptoms. And maybe in people who have amyloid in their brain who are otherwise healthy and maybe in their 60s, maybe those people, there will be the ability to prevent dementia. But those are by no means the majority of the population. So these are all hypotheses that are going to be tested in the years to come. So how are we doing this? Well, we've, with support from a number of philanthropists, have been able to launch the Richmond Family Precision Medicine Center of Excellence. The goal is to apply concepts and culture of precision medicine to develop new therapies. I'm happy to refer you to a vision paper if you're interested. I can actually put it in the chat if you want to have a look at it later on. This is the Brain Trust faculty of the center. We put this paper together, and it's got a figure that I won't spend too much time explaining, but takes a broader, more nuanced approach to developing therapies. So what are we doing? Well, our ultimate goal is to produce a differentiation of subgroups, and again, represented here by different colors. But now we're taking advantage of the Johns Hopkins electronic medical records. We're going to use information in these medical records. I'll show you just a little bit more about that in a moment. As well as in the instances where we have it, digital data on clinically obtained MRIs for people who have a medical record. And we're going to use this as a first pass to try and differentiate subgroups, here again represented with different colors. So you see here, the initial pass, we hope to differentiate small areas and start getting a feel for what the subgroups are. But still, there's a fair bit of overlap. And if you look at this little figure here, I think you'll appreciate it. It's not as clear a differentiation as we see in the figure bottom right. In the next stage, in the meantime, we're developing a biomarker suite so that with, actually, I should show 5 tubes of blood, which are less than 40 cc's. We're able to get a number of biomarkers, plasma, DNA, to produce what are called polygenic risk scores, exosome or extracellular vesicles. We'll talk about those as well. And we're also able to obtain PBMCs. We use those blood cells in one of the labs associated with the center to produce stem cells that you see here. And from those, they are differentiated into neurons, astrocytes, and other brain cells an organoid. And so combining the clinical subtyping information with the biologic subtyping, we hope eventually to land on combined phenotypes that are therapeutically relevant. So this is a map of the area around Baltimore, Washington, where we're situated. This is Baltimore, this is Washington. These little golden domes are all the Johns Hopkins locations. We are a health system in the area. There are 5 hospitals in the area. 1 is in DC, 4 are in Maryland, and all of these other represent outpatient primary care clinics. Everybody who's seen in Hopkins has a medical record in a system called EPIC. This is intended, I suppose, to look a little bit like the London Underground, but it's nowhere near as efficient and easy to use as the London Underground. At least it reminds me of that because I was born in London. And so what we are essentially doing is we are collecting data from every visit. And so we have in our hands right now, and we've started analyzing records from 126,000 unique patients, either seen at our memory center or are in primary care with a cognitive diagnosis or are 65 years old or older. We have pretty much every piece of data in the medical record. So that's one piece of information that we're obtaining. The other is we are able we've actually expanded from 300 to over 1,000 clinically acquired brain MRIs. Are really very impressive teams are able to take the digital information. As you can see here, a scan has on the order of 1.2 million individual pixels. These are little smaller parts of the scan. And using automated methodologies, so in the old days when I was growing up, you would go to a scan, sit in front of it, and you would trace it with a cursor. We don't need to do that anymore. There are automated capabilities. This one allows us to produce volume clustering. So we can look at atrophy patterns across many different individuals. And here's a very preliminary analysis suggesting if you look at the distribution of atrophy in people with dementia, there are different patterns which we think mean different things. For us, this is a way of differentiating dementia based on its pattern of spread in the brain. So if you have Alzheimer's disease in the brain and you've got one of these 4 or 5 different atrophy patterns, do you have a different disease that's going to lead to a different therapy is really what the hypothesis is. We are moving on now with automated methodologies to look at white matter change. As clinicians, I suspect you see a lot of these images that you have top right. You have a brain scan. You see a lot of these things that we call white matter changes. They can be periventricular, they can be deep subcortical, they can come in punctate forms like a little ditzel here, or they could be confluent. The idea is to create automatic methodologies that these are quantified in terms of volume again. So how much white matter change exists. This is an example of how the automated system is quantifying this little, what I call ditzel up here, top right, and these ventricular caps as well. And so if you apply this over 1,000 scans, and you combine that also with the atrophy patterns that we have from the same brains, are we starting to put together patterns of brain damage that are going to be helpful and move from what we typically see as visual reads? We get an MRI, the radiologist looked at the top right scan here and says, oh yeah, okay, this is moderate to severe white matter change. But that's not very helpful information. What we need is a much more nuanced, digitally derived measurement, and that's where we are using deep learning methodologies to develop these. We're hoping to deploy these moving forward once we have a sense of what they mean in terms of prognosis, and also if we have a sense of whether measuring these over time will be helpful in differentiating different patterns of disease. A few words about EVs in blood. So EV science is probably a very novel product of the last decade or so that has really exploded. It's based on the recognition that every living cell is producing both proteins, but also extracellular vesicles, which you see here. These are lipid bilayer derived. They come in different forms. But in general, they have a bilayer, they have surface markers, and they have contents, which are referred to as cargos. And the evidence is pretty good now that the surface markers reflect the origin of these, so that neurons, astrocytes, serotonin neurons, dopamine neurons, microglia, these are all brain cells, have different surface markers. And because we can recover these extracellular vesicles in the blood, this gives us, and look at their surface markers, this theoretically gives us the ability to see what's going on inside neurons by looking at the exosomes, the extracellular vesicles they produce that we find in the blood. Great potential as a biomarker, and even though the science is pretty new, with colleagues at the National Institute of Aging and other colleagues at Johns Hopkins, there's pretty solid evidence now that if you look at the tau products, traditional tau products that are inside these EVs, that indeed you can show that these relate to the course of disease in dementia. The big challenge here is to know what the right surface markers are. And actually that understanding is going to come from combining EV science with stem cell science. So let's talk a little bit about stem cell models. I think you all know what a stem cell is. It's a pluripotent stem cell. For a long time, there have been studies of embryonic stem cells, but these come from a single individual. There's a huge amount of controversy about how they are obtained. So about 10 years ago, there was a discovery, maybe a little more than that, that led to a Nobel Prize, whereby taking blood cells, in this case, PBMCs, and essentially putting them in culture and feeding them different substances while they are in culture can lead them to become stem cells. In other words, erase all the epigenetic information, and these now become induced pluripotent stem cells. This is what they look like. It's a simple picture. They kind of look like somewhat amorphous. So now, at the individual level, so you can have mine, you can have Dr. Odoconyero's cells in the lab, and these can be grown by taking a sample of your blood. These stem cells can be grown in a lab within 3 to 4 weeks, and the processes are getting more efficient. So what do you do with these? Well, you then feed them other stuff. It's the adage, you know, you are what you eat. So you feed them certain things to make them stem cells. You then feed the stem cells different stuff, and you can make cortical neurons that typically make glutamate. You can make neurons to produce dopamine. You can make astrocytes. You can make microglia, which are the inflammatory cells of the brain. And you can combine them in 3 dimensions to make organoids. And so far, the technology has made organoids out of just cortical neurons. But now, that's an example, but now there are efforts to make organoids combining cortical neurons with, say, vascular epithelium so that you have a vascularized brain organoid. Well, there are lots of possibilities for using these as biomarkers. One possibility is to test the value of drugs. So, for example, if you have my dopamine neurons growing in your lab, and you want to see how I respond to antipsychotics clinically, maybe you give microdoses of antipsychotics to my dopamine neurons in the lab, and that tells you something about my clinical response. So that's a quick and easy way of learning something that can be very precision medicine oriented. Similarly, if you're worried about brain inflammation and you're interested in whether my microglia will respond to an activation inhibitor, again, you've got a platform where you can test this with no risk to me in the lab and see whether I would be eligible for a particular therapy. So I hope you appreciate the power that comes from these stem cell platforms. So how do we translate that into a subgroup? How do we, because I told you this is all a culture about a subgroup. And I'll try and illustrate that with a few ideas. And these are early ideas, obviously, with somewhat less involvement of blood biomarkers because those are still being developed. So, well, you need a hypothesis. You need to say, I believe there is subgroup X. I want to define the target population. And I'll illustrate that in a moment. I need to come up with some way of defining the target population. I then need some kind of candidate intervention. I need a proof of concept trial and a definitive trial. So let me illustrate that to you here. So here I'm making the point that we have all this information eventually from individuals, again, different colors. We combine it and we get these different subgroups. But let's start by an example where maybe we hypothesize there's a vascular subgroup, and I'll talk to you about that in a moment. And maybe we use a brain imaging capability to define them. So if you look at people with Alzheimer's dementia, in other words, people who don't have vascular dementia, but Alzheimer's dementia, there's pretty solid clinical evidence that the more vascular risk factors you have, the faster your Alzheimer's dementia will progress. So that's got to mean something, is that cognitive decline can be influenced both by the amyloid tau or the ATN processes, as we refer to them right now, but also from vascular disease. But in individual people, we don't know really how much each process contributes to decline. It could be that there's some people with amyloid predominant, in other words, brains where the vascular activity is quite normal, and any cognitive decline maybe is driven by amyloid tau and neurodegeneration. Remember the point I made earlier, maybe there's room for tau therapies. This might be a group of individuals where there's really nothing else going on, where amyloid may be the major driver of decline, and maybe it's in that subgroup that the amyloid drugs are effective. But what if there are people who have a vascular predominant condition? So here we've got the big arrow in vascular, sorry. And in this instance, maybe drugs targeting vascular disease may be effective. Fair enough, conceptually that makes sense. But what exactly is a vascular process and how do we measure it? So by the time people have strokes or white matter change, it's probably too late. Those are events that have happened, there's dead brain tissue. And so probably where we want to go is even earlier than that and try and target perfusion of the brain. Perfusion seems to be variable across the brain, and across people. And so we need some kind of technology or capability to decide if an individual person's brain does have a problem with perfusion. We need a way to measure it, and we need that way to help us decide whether a therapy is working. So we want to identify people where vascular factors play a major role. And the technique that was developed at Hopkins and is being moved into trials pretty soon is called cerebrovascular reactivity measurement, or CVR, or whole brain CVR. Essentially, someone is in an MRI scanner. There is an MRI scan beforehand that quantifies perfusion across different parts of the brain. And then you have that person inhale a small amount of CO2. It's uncomfortable, but not dangerous. You take another scan, and the CO2 inhalation acts as a stress to the brain, which typically should be increasing its perfusion in response to the CO2. You need more oxygen to get rid of the CO2. But my colleagues at Hopkins have shown that, in fact, the increase in CVR is impaired in a subgroup of people who have mild cognitive impairment and dementia. And as you can see, impaired people on average have low CVRs, but even within that group, there's variability. So people with MCI dementia have perfusion in some instances that looks pretty normal, but they also have perfusion that's very significantly reduced. So instead of increasing amount of oxygen flow after CO2 exposure, they either have no increase or in some instances have a reduction. So those are the people that we're interested in, people whose response to CO2 is impaired, and we want to give them a therapy. And so we want to improve cerebrovascular activity in people with low CVR. And we're thinking that from animal models, atorvastatin, a widely available statin for cholesterol therapy, in animal models does seem to improve brain perfusion. And so we're trying to see whether this happens in people with MCI. So we're doing an open label trial for target engagement. Can we take people who have MCI or not dementia in this case, measure CVR before and after and see what happens? So this then is a vascular subgroup to AD dementia. But if you then extend this, we have the idea of a vascular group, an inflammatory group, a metabolic, and for each of these, we are developing ways of defining the subgroups and therapies, and maybe you can already see in your mind how our various biomarkers are going to play a role. But I do want to talk about another very interesting subgroup that we're looking at right now. These are individuals who develop neuropsychiatric symptoms early on that we think might have low serotonin in their brains, and we're calling these serotonin. Here, can you all please mute? There's
Letitia, can you please mute your mic?
Thank you.
Thank you.
So here we're interested in using a clinical description to see whether we can define a subgroup that should be targeted with a serotonin drug. I'll accelerate a little bit because we're coming to the end of my time, I understand. So we showed many years ago that over the course of dementia, everybody develops neuropsychiatric symptoms. Here are the kinds of symptoms you see. Each of these bars are a different time point and showing what fraction of the population has had the individual symptom over the time point. So it starts from baseline, where delusions affect about 18%. And over time, after 5 years, we have by then about a little over 60% have developed delusions. If you extend that to any neuropsychiatric, see that eventually everybody develops these. We also know that having these symptoms is bad for patients.
Letitia, please mute your mic. Or let me ask admin to mute everybody here. Letitia, please mute your mic.
So after the onset of dementia, if you have neuropsychiatric symptoms early, you move to severe dementia faster and you have accelerated mortality. So the presence of neuropsychiatric symptoms seems to reset the clock and lead to faster dementia progression. In fact, we and many others have shown that if you have neuropsychiatric symptoms before dementia, you get dementia faster. So this accelerant effect, if you will, of neuropsychiatric symptoms applies to before dementia or even before MCI, suggesting that nuanced neuropsychiatric symptoms later in life are big risk factors for MCI, as Jonas Geda showed many years ago. And a paper a couple of years back from our group, in fact, suggested that the predominant presentation before cognitive diagnosis is for people to have neuropsychiatric symptoms. So for people who go from normal to MCI, 55% have neuropsych symptoms before MCI. For people who go from normal to dementia via MCI, 55% have NPS before MCI. This is a different group. And people who go from normal to dementia, 64%. So people who go faster, in fact, don't even go through the MCI stage, but they have neuropsychiatric symptoms earlier, suggesting that neuropsychiatric symptoms could be very important as a therapeutic target. A few years back with colleagues in Argentina, we defined the construct of mild behavioral impairment. So we weren't just counting how many symptoms you had, but we wanted the occurrence of the symptoms to be somewhat syndromic. And we were able to show that if you have MBI with the original Tarragano criteria in the presence of cognitive impairment, with just MCI, here's your survival curve to dementia. But if you have MBI with or without MCI, your progression to dementia was much faster. And in a later study, Tarragano was able to show that if you split out, and this was a challenge for the original MBI definition, we had people with psychiatric disorders later in life. If you split that group out, that group doesn't seem to have accelerated progression to dementia. But now the MBI group is even faster in progressing to dementia. Again, making the point that if you have syndromic appearance of NPS, the syndrome now we call MBI, you move to dementia faster. The syndrome was defined in a paper in 2015 from a professional interest area group that I led, but really this was the work that Zainer Ismail put together with many other colleagues who you see here. The criteria really refer to changes in behavior or personality that are evident. Person is 50 or older, they persist at least intermittently for 6 months. They are a clear change, and they occur in one of these 5 areas: motivation, mood, impulse control, social context, and perception or thought content. They are impactful socially, et cetera. So these criteria now have been employed in dozens of studies around the world. We want you to think of this as a parallel to MCI. So you go from usual aging, you can go to MCI, you can go to MBI, you can go to both, but these seem to be intermediates before dementia. Many studies now have suggested that MBI is a risk factor for dementia using the iStart criteria. I'm not going to belabor these. I'll make my slides available. But the odds ratio for going from MCI to dementia, if there is MBI versus no MBI, is 2, so twice as fast. In the National Alzheimer's Coordinating Center data set, which is a large data set from the Alzheimer's centers in the US. In a French clinic, again, MCI to dementia, odds ratio was slightly higher if you have MBI versus no MBI. Colleagues in Japan suggested that if you have MBI versus other psychiatric disorders, your odds ratio was 8, reinforcing the idea that MBI is different from the more traditional psychiatric disorders we might see in later life. And there's in cognitively unimpaired individuals with subjective cognitive complaints, if they also had MBI. So these are older people, cognitively normal, no MCI, but they feel that they are having cognitive complaints beyond a certain threshold. If they also have MBI, they are at 8 times higher risk of progressing either to dementia or MCI. So having MBI is not a good thing, it seems. And there's a little bit of evidence now from a online database, the UCSF Brain Health Registry. These were 113 individuals who were cognitively unimpaired. They had MBI that was moderate severity using the MBIC. It's a scale we developed to quantify MBI. A year later, 65% still had moderate to severe MBI. 35%, so 1/3 actually, the MBI got better. And if you look at their cognitive scores, higher being worse, those who had persistent MBI had much higher, 1/3 higher cognitive scores a year later, suggesting that if your MBI gets better, maybe your cognitive outcomes improve. And this raises the question as to whether we can find a way to get MBI better with the therapy. Again, in the interest of time and for a Q&A, I'm going to skip over this a little bit, but I want to make the point that MBI now is clearly linked to 2 brain pathophysiologies. It's linked to the amyloid tau neuronal degeneration axis, but it's also linked to serotonin loss. Serotonin loss does happen with aging. There are probably other processes, but how this happens is not so well understood. But the model we have right now is that whereas the amyloid cascade might apply to the cognitive change and the behavior change, there is an additional variable of loss of the serotonin system with aging, which might be worsened by amyloid and tau, and might, in an interactive fashion, create a circular feedback loop where the more serotonin loss you have from aging, the worse off you are cognitively. Again, raising the question, what if we address the serotonin loss? Are we going to have a better outcome? And so we are proposing an intervention with escitalopram, and we're hoping to get funding for that study over the next couple of years. Why we're choosing escitalopram, there's both clinical and laboratory evidence that it has direct effects on amyloid production and amyloid plaque deposition. And so we're thinking that it might be a dual mechanism drug that both addresses the ATN pathway that we have here, but also the serotonin pathway. So This is then a hypothesis of a serotopenic subgroup. Ideally, we'd like to be able to directly measure the amount of serotonin someone has. And our target population in our proposed study are individuals with MCI or subjective cognitive decline who have moderate or more severe MBI. And so this is sort of what the study would look like. Very early, it's phase 2. And we're hoping, therefore, to target MBI as a means of presenting dementia. So I think I gave you a pretty speedy overview of precision medicine, trying to hone it down as a way of preventing dementia and looking at 2 very specific approaches that this method implies. So I'm going to end there and thank you for your attention. And if Dr. Odokonyeru agrees, I'm more than happy to take questions.
Wow. Thank you very much, Dr. Constantine. We now know why your hair is gray from dementia studies all these years. You have shed light like we haven't seen before in dementia, but also with the precision medicine. I want to believe that the members who are available here are as excited to hear some of these things as I have been. And before you started, I thought you said you recognized somebody. So let me pick her out. I want to imagine it's a she. I know that we have a Johns Hopkins alumnus among us. And because of the utmost respect we have for the talk you've given, I'm going to have to ask Dr. Ethel, who is an Johns Hopkins, to take the privilege of asking the first question.
That's what I was thinking. I'm not sure if you lost me or I lost you. Okay, something happened, but I think I'm back now. I'm not sure if I lost you or you lost me.
No, I think it was me. I flickered off for a second there. And for that matter, I've also lost the question that Professor Noelin had typed. So I am going to have to ask her to unmute. I know she's on. And please ask the question.
So thank you very much. Sorry, I have to take off one of these machines. Thank you very much, Dr. Lyketsos, for that very enlightening talk. My question is on your opinion about the average time that lapses between the show of the neuropsychiatric presentation in patients that may later develop dementia. What's your experience of that time lag, and what do we do for them in between after managing the psychiatric presentation, whether it's come through a manic-like picture or a paranoid-like picture when they come the first time?
Yeah, thank you. Wonderful question. We don't have good data that would tell us what the average time frame is. It's on the order of a few years, we think, 3 to 5. So in my own clinical practice, it's not unusual that I see individuals who have primarily mood symptoms, not usually mania or psychosis, but it's things like irritability or crankiness or sort of a mental subjective distress that can be quite persistent. And those folks will typically progress on to dementia on the order of 2 to 4 years in my own experience. But that's the experience of one clinician, and I think we take that with a grain of salt. What do we do to help them? I think we do what we know to do right now. So I think to me it makes sense, for example, for this predominant group, which have these mood symptoms, maybe 60% of all of these folks with MBI. Using an SSRI it tends to help the symptoms a lot. What it does to the downstream outcomes, I think we really don't know and can't know at this point. I'm always hesitant in someone who has psychosis-like symptoms, say a 78-year-old psychosis-like symptoms. Maybe I'm worried about dementia, adding an antipsychotic. It makes me nervous because some fraction of these people are on their way to Lewy body dementia. And in Lewy body dementia can actually be made much worse by the addition of an antipsychotic. On the other hand, there are instances where psychosis is dangerous. And so we perhaps use a low risk or lower risk atypical antipsychotic. At least that's what I would do here.
Thank you.
Dr. Esso, your hand is up. Please unmute and make your comment or question.
Thank you, Chair. And thank you, Dr. Lyketsos, long time. That was a great talk. It's actually very exciting. And I want to be sure, are you now focusing your treatment trials on patients with MBI? Because we know that MBI is a risk factor for developing dementia. So if you can clarify that, but then also to what extent are you integrating this kind of practice, precision treatment, into routine care, or is it still at experimental levels? Thank you.
Yeah, great questions. It's great to see you indeed. The trial I put out there is much more nuanced than I was able to show. We have not started it. We're starting to get funding. That will be our first MBI trial if we do it. There's a group around us that it's not just me, obviously. It takes a lot of people to get these kind of trials. So to your question, no, we're not doing MBI trials yet, but we want to go there. And I think part of the challenge is, what's the drug? What are we going to do? Is it really an SSRI? Should it be something else? And maybe we need to refine MBI more and do direct measurement of serotonin. The other question, are we using this precision medicine approach in practice? The answer is no. It's still very much in a thinking stage. I will say that other colleagues in our center, like Paul Rosenberg, I don't think he might have been here, and I don't know if you met him when you were here, but he's focusing more on vascular factors and vascular cognitive impairment. So I gave you an example of the atorvastatin open label trial he's doing now. And there are other colleagues who are focused on inflammation or metabolic disorders. But these are still very experimental. We don't know that this idea is going to pan out. It might not. And for all we know, it might be the current generation of amyloid drugs are going to prove their mettle if they just need to give them a whole lot earlier. And that obviously would be a good outcome. I'm skeptical of that. So not still very experimental, but I'm trying to encourage clinicians to think this way. It's not that different from how we think clinically, but bringing clinical wisdom into this to help us think of, well, what's a subgroup? And why might there be a subgroup? And how does that matter to therapeutics? I think it's the clinical wisdom I'm trying to engage in this battle.
Great. We are 6 minutes over time, but we can take 2 more questions. One is already on the chat from Dr. Emma Mwesiga, who wonders, he always thought hypotheses for the precision medicine studies were generated from large sample sizes. Is this a correct assumption, he asks?
Yeah, I think you're right. You're focusing on the generation of hypotheses. And the answer is yes, the best off you're going to do is with large samples. So our sample size is 126,000 right now from the data systems that we have, and we hope to grow it. And we had this very conversation the other day. We have about 200 quantifiable variables on these 120,000 people. And our big data experts are saying that that's plenty of a sample to look at patterns for 200 variables that predict dementia. So yes, that's where you start. So we're going to do an agnostic deep learning study, put all those 200 variables into the mix and see if we can even get 1 or 2 patterns. I'd be happy if we get a pattern that fits maybe 10% of people, because you got to start somewhere.
Excellent. Dr. Lyketsos, I think I'll take the last one since I don't see any more hands. I have a comment and a question. The comment is, listening to you right now, I see limitless potential in just exploring this precision medicine, but feels to me a bit like this is a Pandora's box. Like, where does it end? Because it looks like one subgroup would lead to even a further subgroup, it leads to a further subgroup. Is there an end to it? And can we know when we have reached the end?
Yeah.
My second question is, have we now shielded ourselves off of external influences, environmental influences, and we are looking more inward now and examining the individual, biology alone? What about the environment? What role does it play in precision medicine?
Yeah, well, wonderful question. So on your first question, I think it ends when we have a treatment or when we test treatments in a subgroup and they're not effective. Yeah, I think we learn just as much from targeting a therapy that doesn't pan out. Well, we have a better outcome if we get a therapy that does work. But so I think that's where it ends. It ends with testing therapies and seeing if that's a way of validating a subgroup is you come up with a therapy and you test it. I love your question about the environment. Actually, I think it's a very important question because there is the reductionistic risk that this is all going to become about DNA. In fact, some of my colleagues scoff at the idea that you're going to look at anything but DNA. One of the beauties of our data set is we know where people live. We can map the kinds of environments that they live in from the point of view of air quality, for example, or we can get indirect senses of nutrition. Do they live, for example, in areas where there are no good grocery stores, would be just one example. So there's a lot we can come up with by knowing where people live. We have a sense of their socioeconomic status. We know a lot about the work they did, how educated they are. So there's plenty in the data set that is not biology that we think is going to be a modifier. And I will say that, and this I suppose would say is biology, I think age really matters. I think we have people who make it all the way to 90 and then they get dementia and they are healthy otherwise. I think those are very different people than folks who get dementia at 68 or 70, or from people who've had diabetes for 20 years and don't get dementia, because you should get dementia if you have diabetes after 20 years. So I think you're raising an important point, and we got to remember that precision medicine is not just biology, but it's really the combination of biology and environmental variables that's going to help us define subgroups. It's all about, is the treatment going to work?
Dr. Lyketsos, I could listen to you all evening, and I'm sure the members agree. Sadly, we are always, as human beings, in a race against time, and on this occasion, we are losing badly. So allow me to offer my sincere gratitude to you for such a wonderful presentation, very informative, very educative. Some words I've learned for the first time. And it's just amazing where precision medicine could take us. The potential is so huge. I'm going to ask the head of Department of Psychiatry, Professor Noelin, to give you a vote of thanks, and then we'll bring proceedings to an end. But I would personally look forward to your next talk when it comes around.
Thank you. Thank you very much for the pleasure.
Yeah, it's been a wonderful pleasure for us to have you. We've always read about, the works that you do. was telling colleagues in the department about, your name and, really it has been wonderful for us to have the chance to be able to meet you, even though virtually, and we look forward for more interactions through the collaboration we now have with Johns Hopkins and Makerere University. And we're indeed very grateful for keeping us up to pace with what's happening in these important fields of mental health. Thank you so much for your time.
I appreciate the honor. Thank you.